So again, all the stuff that we are going to talk about today, we've talked about in great detail this whole semester, but this is really what it's all going to come back to, no matter what type of arrhythmia, dysrhythmia, or cardiac issue that you're dealing with, is going to be stroke volume times heart rate. One of those problems in the equation are going to be the issue. Cardiac output, y'all heard me say this one of the first days in class. Pretty much everything that we do, especially cardiac management wise, is going to be cardiac output. What do we have to do to restore the equation here? And the equation for cardiac output, stroke volume, which is what? Each stroke, right? Each stroke. Heart rate is over a minute. So stroke volume is how much volume is out, and how much how much volume is out each stroke, and then heart rate is going to be how many times the heart beats over a minute. And so of course we know there's several variables that affect that, right? Too fast, too slow, or is the heart moving at all? And if there is not something that is affecting the equation in that aspect, then we need to figure out what it is and what we need to do to fix it. But most of the things that we deal with, even if it's not dysrhythmia, will affect stroke volume, right? Think about left-sided heart failure. That's going to affect stroke volume, right? Because of contraction. Maybe even right-sided heart failure, or pulmonal or something like that. What about MI? Well, we know that MI eventually leads to dysrhythmia, right? But before that, MI, damaged myocardial tissue, is going to do what? It's not going to stroke well, right? What about hypertensive issues? Well, that's not directly affecting the pump, but it is directly affecting the pump, because if your systemic vascular resistance is high, the heart has to pump harder to overcome that, so that means that it is working harder, and so it's having to maintain a certain amount of force to maintain stroke volume. And so what's going to happen? It's going to wear out, or it's going to hypertrophy, or it's going to do something to where it's not going to work right. And so bottom line is that this works both pre-hospital or in the acute setting, and for cardiac management across the board. For maintenance management, the physicians, when they are managing patients that have cardiac issues, they've got to figure out, what do I have to do to keep the patient's heart from beating too fast all the time? Or what do I need to do to speed the patient's heart up? Or what do I need to do to make the heart contract better? And so we base all of our treatments off of our assessment, right? All the way from our initial assessment, doing our diagnostic tools, using our eyes, our hands, everything else. We decide based off of our clinical judgment how we're going to treat that patient. And remember, we don't just treat what we see on the monitor. We treat the overall picture. We treat what the patient is looking like, right? So we do treat our monitor, though, because our monitor is a diagnostic tool. It does help us decide how we treat that patient. So in most cases, there's a problem with one of the factors in the equation. If you can figure out what aspect of cardiac output is being affected, then you can try to fix that one thing, and the other part should come up. Is it too fast? Is it too slow? Is it moving at all? That's going to be the easiest to treat there, right? And if it's a normal rate, then what other factor is affecting cardiac output? So again, remember, stroke volume times heart rate equals cardiac output. So the first thing we will look at is our too slow. So I told you when we first started learning management, essentially you've got three types of management across the board. You've got your non-invasive, which is there's not much by way of non-invasive for too slow. You've got your pharmacological, and you've got your electrical. And if you think of all three of these categories right here that we mentioned, is it too fast? Is it too slow? Is it moving at all? There is something in each one of those categories, essentially, except for maybe bradycardia with non-invasive, but you have vagal in tachycardias, right? You have CPR. I know that is, that's not inside the body, so I consider that non-invasive, just doing compressions. But then you got your pharmacological and your electrical therapy. So with our bradycardias, remember we've got 3 drugs on our algorithm, right? You all right?
I was whatever that was. The way you just continued that whole little process was something else. I wasn't prepared.
All right. Well, you've got 3 types of drugs on your bradycardia algorithm. You got atropine. That's going to be your first line drug. What's my dosage of atropine for bradycardia?
0.5 milligrams IV up to max of 3 milligrams.
I hear you, Jody. Good job. So atropine is my first line drug, and we will give atropine for any of our bradycardias. Now, we do know that our heart blocks fall under the bradycardia algorithm. We also know that the preferred treatment, or essentially the treatment that is what is going to work, hopefully, for heart blocks is not necessarily going to be atropine, but it's going to be pacing. But since it falls under the algorithm, you can still go ahead and give atropine, but the preferred treatment for your high-degree AV blocks, second-degree type 2 and third-degree especially, would be pacing. But getting back to just your normal tried and true bradycardias. What's going to fall under bradycardia? The main one is sinus bradycardia. How do we know it's a sinus bradycardia? It's slow and it has a P wave. Or a upright P wave. That's before the QRS. Alright? If you go along your algorithm, you'll give your atropine. Is it refractory or is it non-responsive to atropine? Then you go to dopamine or transcutaneous pacing. It's not this, then this, then this. You've got either your drug therapy or your electrical therapy, right? So your drug therapy would be dopamine or epinephrine. Most likely you're going to pull out your pre-mixed bag of dopamine. All right? Which is going to be what? What's your dosage on that? Remember, it's special. It's in bradycardia. Yeah, 2 to 20 mics per kg per minute. Then, or you have your epinephrine, which is not in per kg. It's just 2 to 10 mics per minute. Or you got your transcutaneous pacing or transvenous pacing, but transvenous pacing is not something we're going to do in the field. Yes, sir?
When would we want to do an epinephrine drip over a dopamine drip?
Either or. That's why it's an added vasopressor with sympathomimetic properties. And so most of the case for you is going to be dopamine because you've already got your pre-mixed bag and you're able to just go ahead and give it and titrate it to effect.
Okay.
Now, there are certain situations that go a little bit more advanced than what we're talking about now. You know, certain situations, maybe if they are bradycardic and they're septic, or you know, they're bradycardic and they're hypotensive for some other reason as well. You might consider that. Your transcutaneous pacing, your standard there is essentially set your beats per minute anywhere from 60 to 80. I like to just go with a happy medium for class just for standard, and it's about 70. All right. 60 is the low end of normal. 80 is a little, I guess it's within the normal range, but I just like to set it about 70. But you will call a physician in this situation because it is a Cat B. And so you apply your milliamps and TB capture. We also want to consider what if we're going to be pacing a patient. What? Sedation, yes, pre-medication. Now, We know that on the monitor we will confirm we have pacing by what? Pacing spikes before each QRS. Now how else? We will do electrical capture confirmation, and we also need to do mechanical capture confirmation. Alright, we want to check our pulse, make sure that our pulse matches with each complex. Also want to check what? Yeah, we want to look at perfusion signs, skin color, also blood pressure, and then mental status as well, because if your heart is pumping blood back to your noggin, you should be a little more responsive. So your major ECG rhythms classified as bradycardia, that's going to be your sinus, your first degree AV block. Remember, first degree AV block is going to be it is not going to be a rhythm itself, it's just going to be an addendum to a rhythm, okay? Usually it's going to be a sinus, because for it to be a first degree AV block, it's got to have a prolonged PRI, right? If we are treating a patient with a first degree AV block, in the bradycardia algorithm, we're not really treating the AV block, we're treating the bradycardia. Your second degree AV block, your Wankenbach or your Mobitz 1 or your Type 1, whichever one you prefer. I think Chris has decided he's only going to call it one thing and one thing only. And you got your Type 2, your Mobitz 2. Your Type 1 prolonged until you drop a beat, and then your Type 2, you've got intermittent beats with drop beats. And then your third degree AV block, that's going to be your divorce, right? It's going to be your complete block between your SA node and your ventricular conduction. Okay? Just quickly looking at some of these drugs, again, atropine, it is your anticholinergic. Cholinergic parasympathetic response. A parasympathetic response, especially when the vagal nerve is activated, is going to be releasing acetylcholine, working on those receptors there, dropping the heart rate. So atropine will assist in speeding up the heart by blocking the parasympathetic response, which is a total different mechanism of action from epinephrine or dopamine. Remember, both of those are sympathomimetics. They do nothing with the parasympathetic nervous system. This is an anticholinergic or a parasympatholytic, and it does nothing with the sympathetic nervous system. Does that make sense to you guys? Understanding the mechanism there is important when it comes to these drugs. Atropine will assist in speeding up the heart by blocking the parasympathetic response, meaning that we vagaled in this situation. We got this rush of acetylcholine, and through some complex chemical reactions here in blocking, we essentially say, hey, watch out, acetylcholine, get off of the SA node. You're not going to make it slow down any farther. Now we're going to try to speed it up again. So again, slowed heart rate equals poor cardiac output, right? That's our equation there, remember? Cardiac output, stroke volume times heart rate. In bradycardia, stroke volume times heart rate equals cardiac output. So in Brady, if our heart rate goes down, our stroke volume goes down. We don't want to give a drug that's going to make the heart stroke harder right now. We don't want to give an inotropic agent. We want to give something that's going to speed the heart rate up, because if the heart rate will speed up, then we will be able to get a better stroke volume out. Okay? Alright, so what about dopamine? Dopamine is a sympathomimetic, meaning it works on the what? Sympathetic nervous system. So you would expect a sympathetic response, especially cardiac, inotropic, and you've also got some vasoactive response as well. We give dopamine in bradycardia for rate control to speed the heart rate up. We also give dopamine in which other algorithm? Huh? Yeah, post-cardiac arrest. Return of spontaneous circulation. The dosage is going to be a little bit different there. It's 5 to 10 instead of 2 to 20. Remember, dopamine is dose dependent. When you get above, I believe it's around 10 mites, 10 to 12, somewhere around in there, when you start getting above that, you start working on your adrenergic, alpha adrenergic receptors. which have a lot of effect on heart rate. All right. When you're a little bit lower, you work more on some of your there's renal, and then there's also some of the receptors that help with the inotropic properties as well. Remember, if somebody is in cardiac or return to spontaneous circulation, they're in post-cardiac arrest, we may not want to put a huge strain on their heart, but we may want to give something that's going to help it pump a little bit better, and maybe even help vasoactively as well. We give dopamine and bradycardia for rate control to speed the heart rate up. Remember, it is titrated. You got to look at your blood pressure and you got to look at your heart rate. Remember, it's in mics per kg per minute, so we want to be careful that we don't get that confused with milligrams. I think that's been kind of pounded into your head a lot this semester, so I don't feel like you'll get that confused. But the good thing about dopamine is that there are resources available in your Alabama protocols. There are different types of apps that you can use that will plug in the weight, you plug in your initial dosage, and it'll give you what you need. All right. However, there is a pretty simple formula as long as it's in a 1600 mic concentration, which is going to be what you typically have in a pre-made bag. Okay. And so essentially, use your dose times weight times 60 drips, because you're always going to use a 60 drip set, right? Divided by 1600. Have I showed you all this before? I think I have.
Work a problem with that.
Do what?
You had us, when you gave us the drug map, you had us work a dopamine problem.
Oh, okay. So, I mean, you know, it's pretty simple here. You got, let's say that you're wanting to give, I don't know, 5 mics. You want to get 5 mics per kg per minute. Let's just go easy. So 5 times, let's say they weigh 220 pounds. How convenient. 100 kilograms times 60 drips divided by 1600. Somebody already got it?
18.75 drops per minute.
Alright, so 18.75 drops. If you are using a pump, you certainly want to try to keep it as close as you can. In this situation with dopamine, this is my personal preference. I don't want to round to 19, even though this is a rounding to 19. I'd rather go to 18 just because I don't want to give too much. So now, if you look, do I have it in here yet? Here is the table that is in the protocol, the Alabama protocols, to help as a quick reference. But this patient weighed 220 pounds at 5 mics per minute. They rounded to 19, but that's what we got was 19. So that makes it pretty easy, right? I mean, it's going to be a rough estimate either way, but, you know, at the end of the day, if it's a grown man, there's not a big difference between 209 and 220 pounds, and so, you know, the difference between 18 and 19 mics, we're going to titrate it regardless. And then with this, they actually say find the patient weight and then move across row to the column for the desired dose. Set a dial-flow to the corresponding flow rate. So that makes it a little easy if you got a dial-flow in there and you can get it. And that does make it a little bit safer too. Your big thing here is that you just want to make sure that it is in a 1600 mic concentration if you're using this formula, which would be 800 milligrams and 500 milliliters, or 400 milligrams and 250 milliliters, which is the most common one that I've seen on the ambulance. Okay? Epi, same sympathomimetic properties of dopamine, except your dose in this is 2 to 10 mics per kg per minute. Alright, so we essentially just went through the bradycardia algorithm. Are there any questions about that? Y'all are familiar with these now, so I don't feel like I need to hang out here a long time with them. Y'all good? Alright, what about our 2 facts? Well, in this situation, we're a little bit opposite here, so what's happening? Our heart rate is going up, but our stroke volume is not following suit. Our stroke volume is going down. Why? It's not allowing for venous filling, so therefore it's not allowing for output, right? Whereas with bradycardia, it may be allowing to fill, but it's not getting what it needs out. like a sloth versus a kangaroo. Do kangaroos go fast? A sloth versus a cheetah. Alright? A sloth usually doesn't, I don't even know where I'm trying to go with this. All I know is that a cheetah wears out pretty quick. He's good for a few seconds and then he wears out, right? Bottom line is that if they're in a tachycardia rhythm, they're not going to get good cardiac output. Now, the thing about the thing about tachyarrhythmias is that you need to determine what is the underlying cause. What is the underlying cause? Especially in a otherwise healthy individual, there's usually something that could be causing that. Now, what if it is a SVT with an underlying cause of something, but they have poor cardiac output, they have signs of poor perfusion? We're still going to treat it in that situation, right? Remember, with our tachyarrhythmia algorithm, we're going down the highway, the tachyarrhythmia highway, and then we get to where we can take the right exit or the left exit. We're in Atlanta, and they have exits to the left too, because they have exits, and they will screw you up if you're in the right side. And suddenly they're like, hey, get off on the left. Anyways, Siri's usually pretty good about warning you. So anyways, right exit, left exit. And your right exit is your drug therapy. Your left exit is your electrical therapy. When do you take your right exit? Protect your rhythms. When Siri tells you to, you should give drugs. Alright, they're symptomatic but stable. Okay, remember, you can be symptomatic but hemodynamically stable. Okay? When they are obviously symptomatic and hemodynamically unstable, then we go to electrical therapy first. Okay? The ventricles are pumping too quick. That should be TOO quick to allow for appropriate filling. Stroke volume is decreased because there's not enough blood filling the ventricles, therefore decreasing output. What falls under your too fast or your tachyarrhythmias? Well, obviously we know our nerocomplex, regular, SVT, reentry pathway. We also have our atrial fibrillation with rapid ventricular response. Atrial flutter if it's causing hemodynamic issues, monomorphic VTAC and polymorphic VTAC. Now, what about VTAC? Well, if they got a pulse, then they fall under this, right? Mm-hmm. Or a wide complex tachycardia of any other uncertain type as well. You got to ask, are the symptoms being caused by the tachycardia? Or is the tachycardia causing the symptoms? I guess that's exactly what I just said. Back up, pump the brakes. One important question you may want to ask is, are the symptoms being caused by the tachycardia? If the symptoms are being caused by the tachycardia, treat the tachycardia. Or is the tachycardia being caused by something else? Does that make sense? That makes sense, I think. Okay. Your tachyarrhythmias that are caused by other things. Probably with adults, dehydration ranks very high. Metabolic issues, fever, maybe some type of sympathetic response. Obviously, illicit drugs, your stimulants, cocaine, crack, that kind of stuff. Meth, Red Bulls. I'm not putting those in the same category, I'm just saying. Red Bulls, some college students or even grown adults on stimulant-type medications, certain medications. Nonetheless, if your tachyarrhythmia is being caused by something else, you've got to treat that something else in order for that tachyarrhythmia really to be treated. Patients with unstable tachy should be treated immediately with sync cardioversion. If a pulseless tachycardia is present, patient should be treated using the pulseless arrest algorithm. You're like in a whole different category there, okay? So remember, you got your narrow complex and you got your wide complex, and both of them will be treated under this algorithm if you have a pulse. Your narrow complex, You want to try vagal maneuvers first, if you can. Remember, this is going to be a non-invasive. Then adenosine, if it's regular. Then beta blocker, calcium channel blocker, could be sotalol according to the algorithm. Could be labetalol. Your calcium channel blocker will most likely be what? What?
Yeah.
Not calcium chloride, opposite.
Deltazim.
Deltazim. Calcium chloride is the remedy for that, the antidote for it, alright? But yes, deltazim or cardizem, okay? If it is a stable, wide, regular, monomorphic, if you look at your algorithm, it does allow adenosine to be given due to some different originations of these rhythms, but in most cases, you probably are going to want to go with an antiarrhythmic infusion. I've really seen most situations where they try cardizem before anything else. You've got to be careful with cardizem, though, because it does cause profound hypotension. So your medications that you may see essentially treating the tachyarrhythmias: adenosine, cardizem, your different beta blockers. Now, your beta blockers do matter. You can't just say, hey, we'll just give XYZ beta blocker, because your beta blockers do block the betas, but do they just block beta 1? Do they just block beta 2? Are they selective or non-selective? And so that's going to play a big role. Do they have some alpha blocking properties as well? Your amiodarone, your class 3 antiarrhythmic that is pretty common with all of your algorithms here. Digoxin, you know, that drug that cardiologists love and hate at the same time, and patients love and hate at the same time, because it can either cause the thing that you're using to treat it, or it can treat the thing that you're using it to treat. Within its therapeutic range, it is a very good drug. It's a cardiac glycoside that is a very good drug for cardiac arrhythmias, and it even has some of the inotropic properties and all that. But you get it outside of that therapeutic range, you're in trouble. Verapamil and also mag sulfate. Mag is just such an interesting drug, isn't it? We talked about that last week, that there's at least 4 different completely opposite things that we can use mag for, right? We use it for eclampsia. We use it for bronchoconstriction. We use it for torsades. You know, there's just different things that it's used for. But I don't know. Some would say that it's a pretty amazing drug. I don't know. I just made that part up too. I've never heard anybody say that, but I do know that they use it for several different things. So, adenosine should be used within the tachy algorithm. Narrow complex, SVT, especially when it's got into that reentry circuit at the AV node, because it does what to the AV node? It slows conduction at the AV node. It slows conduction at the AV node. That's primarily where adenosine works. That's why adenosine doesn't work that great for anything else, because that's primarily where it works. When given as a rapid IV bolus, it slows cardiac conduction, particularly affecting the conduction through the AV node. So even if you've got a patient that is not in a tachyarrhythmia due to that reentry pathway, and we went over that, and y'all told me y'all understood how that works, that circuit, that short circuit. Let's say that it's a atrial fibrillation with a rapid ventricular response. Well, the issue here is not the same electrical conduction that's keeping on going round, going round. I'm trying to think of the song and I can't. But now y'all have it in your head, and that'll be in your head the rest of the day. The atrial fibrillation with a rapid ventricular response is being caused by multiple atrial ectopic foci, where you actually may need an antidysrhythmic to go in and do its business on those ectopic foci. So does that make sense? Does that make sense why adenosine is not an antiarrhythmic? It's not a antidysrhythmic. It slows conduction, but it doesn't work on the cardiac cell itself. Okay. But let's say you've got a patient that's in atrial fibrillation with a rapid ventricular response. If you give adenosine, it's going to still slow conduction at the AV node, at least momentarily, and so that's why you may see that slow down of the rate, and you can actually use adenosine as a diagnostic tool, because you can get that rhythm slow enough to where you can see, hey, it is an irregular atrial fibrillation here, so we need to switch modes and we may need to go to something different. And even if you're going to treat with electricity, if you're going to synchronize cardioverter, it is important to know if it is a regular narrow complex or an irregular narrow complex, because you're going to use two different joules dosages, right? Rapid bolus interrupts re-entry SVT pathways through the AV node and restores sinus rhythm in patients with SVT, allegedly. Okay? So we know that our first dose is 6 milligrams, followed by rapid IV push of 20 milliliters of normal saline. Then we can give an additional dosage of 12 after within 1 to 2 minutes. Give it a little bit of time, but we know that it does have a very short half-life. So if it doesn't work within a minute or so, it's not going to work. So we can try an additional dose, and then we need to move forward to something else. Okay? What about your cardizem? Your diltiazem? It is a calcium channel blocker. It slows conduction, causes peripheral vasodilation, so we very much need to be watching for hypotension with this patient. Okay? Controls ventricular response rates in AFib, A-flutter, and multifocal atrial tachyarrhythmias. Works very well in your tachyarrhythmias. As far as dose-wise goes, the typical dose is 0.25 milligrams per kilogram. And I've told you all that before. Sotalol. Now, the American Heart Association recommends Sotalol, and why? Because it is a beta blocker, and a lot of your beta blockers fall under the antidysrhythmic category as well, but it does have a type 3 antidysrhythmic properties, which means that it does affect some of the potassium movements. Okay? Non-selective beta adrenergic blocking. So what does that mean, non-selective? What? Yeah, it's free love. It don't matter. It loves the beta 1, it loves the beta 2. It does whatever, just free. If you think about on the other end of the spectrum, just to kind of help you understand that, so sotalol is a non-selective beta adrenergic blocking receptor, whereas like something like albuterol is a selective beta 2 adrenergic sympathomimetic. So it selects the beta 2 and works on that, which is why it's a good drug for bronchodilation, right? So our sotalol will work on, and this is important because we know that our beta 1 is our primary cardiac, right?
Yeah.
But it can also work on beta 2 as well. And so essentially this is just a little graphic here of just kind of giving you an idea with the receptors and all that. It affects the receptors in the heart and blood vessels, and it blocks those off so that these cannot lay into that on the walls of the different cells. Okay? All right, amiodarone, class 3 antiarrhythmic agent, used to treat both supraventricular arrhythmias and ventricular arrhythmias. So again, it's another good drug for your tachyarrhythmias. Only thing is that amiodarone long-term has some pretty nasty side effects to the body and some toxicity issues as well. Used primarily to treat VFib and VTAC that occurs during cardiac arrest and is unresponsive to shock delivery, CPR, and vasopressors. So what does that mean? That means that we use amiodarone if we have a patient that is in refractory VTAC. What does that mean? It means that it hasn't been responsive to any other treatment. Okay? Just give me a little hint. Y'all got a quiz before you leave today, and I've given you several answers to this quiz. What's your dose? You got 2 doses. Cardiac arrest dose. 300 milligrams push. Followed by 150 milligrams, whereas in your tachyarrhythmia, you got 150 over 10 minutes, followed by what? Alright, is it? I don't think it's all about 3 minutes. Yeah. Repeat 150 if needed, but then if you do have conversion, then you do want to do a 360 over 6 hours, 1 milligram per minute, and then they're going to allegedly do another infusion there. So that's just the recommendation there, okay? Max sulfate, 1 to 2 grams for torsades. Simple enough. Now this is a polymorphic ventricular tachycardia. What about shocking? Well, if they still got pulse, then we want to give MAG because it's usually issue with MAG. I've only, in my own experience, I've only seen torsades working in the hospital with renal patients when their electrolytes start getting off and all that. Now, it quickly went from torsades to cardiac arrest, and that was a different, story there. But torsades, certainly one of the main causes is because of MAG deficiency there. Okay. So we kind of went through that algorithm, the adult tachycardia algorithm. Big thing here is that 2 roads diverge at the wood. Which one are you going to take? Well, you may take the one that is electrical therapy, or you may take the one that is pharmacological therapy. It's all based on patient presentation and their hemodynamics, okay? If that patient is showing anything that could be signs of shock, hypotension, altered mental status, any other signs of shock, ischemic chest discomfort, or acute heart failure, then we go straight to the critical treatment there, and we go ahead and shock. Okay? And then, of course, additional meds you may see epinephrine, vasopressin, lidocaine. Very rarely would you see epi or vasopressin. I don't know why it's there. Oh, VTAC and fibrillation. Okay. And then lidocaine. All right. So epi, we're giving this in cardiac arrest for its vasoconstrictive properties. All right. We're not giving epinephrine to do anything antiarrhythmic-wise. Why? Because it's not an antiarrhythmic. We're not giving epinephrine to speed up the heart. Why? Because the heart ain't beating. So you can't really speed up something that ain't beating. Why do we give epinephrine? So that it will work on the systemic vessels as almost a artificial type shock mechanism. All right? Trying to shunt blood, trying to essentially help the heart pump. Why do we give epinephrine? To really make the heart a more efficient pump. If it's got a little bit smaller container to pump up against, and if the pressure is a little bit higher, that will help move the pressure around a lot easier. Does that make sense? Epinephrine binds directly to alpha-1 adrenergic receptors of the blood vessels, causing direct vasoconstriction, thus improving perfusion pressure to the brain and heart. Important as far as like getting brain oxygen to the brain. And then your cardiac output, epinephrine also binds to beta-1 adrenergic receptors of the heart. This will, if the heart is beating, it will increase heart rate because it is alpha adrenergic receptor 1 or beta 1. Not alpha, forget I said alpha. Beta 1 receptors, increasing heart muscle contractility, so it might help with some inotropy as well. And then increasing conductivity through the AV node. So epi kind of does all 3 of those OP things. Remember, chronotropy, inotropy, and dromotropy. So this is the easiest one to remember. 1 milligram of a 1 to 10,000 every 3 to 5 minutes for cardiac arrest.
For IV infusion for bradycardia, 1 milligram of epi is mixed with 500 milliliters of normal saline or D5W, and it should be titrated to effect. Or ET2, we're going to double our dosage, diluted 2 to 2.5 diluted in 10 cc's. So, lidocaine. I read something the other day, and I am recording this. Hopefully it'll work right. And so if somebody else is listening and it's a long time from now, then I don't know what the outcome's going to be. But I did read something the other day where American Heart Association is kind of like, hey, you know, we've kind of abused lidocaine and we just kind of kicked it to the curb. But, you know, maybe there is some use for it. And so I'm not saying it's going to make it back onto the algorithm as a first line, but there is a little more attention being paid back to lidocaine. Now, lidocaine was removed in the 2010 simplified cardiac arrest diagram, but it is still considered a suitable alternative for amiodarone, which is good for a lot of ambulance services that are too cheap to buy amiodarone. Lidocaine will work ventricularly, but it has no effect on the atrial conduction. Okay. Lidocaine is used intravenously for the treatment of ventricular arrhythmias. It can be used for VTAC with a pulse or for the pulseless VTAC VFib. Okay. Your initial dose for cardiac arrest, 1 to 1.5 milligrams per kilogram IV. And then if it's refractory, you can half the dose, 0.5 to 0.75 milligrams per kilogram. And then you see the dose for stable VTAC, wide complex tachycardia of uncertain type and significant ectopy, 0.5 to 0.75 up to 1 to 1.5 milligrams per kilogram. Now, your maintenance infusion, if you convert, then your maintenance infusion will look something like this, where it's, if you decide you want to give 1 milligram, it will be 15 milliliters per minute, or per 15 drips per milliliter. 30. This is your drip set. This is a clock method that kind of works a little bit like that table we saw for dopamine. It just kind of gives you an idea of where to set your drip rate if you are trying to start that infusion. Okay. And then finally getting into our other part of our algorithm here. So we looked at too fast, we looked at too slow, we looked at too fast, and then what if it ain't moving? Get it moving. That's your number one priority there. Whether you're doing manual compressions or you put them on some type of device, they need compressions. And they need immediate compressions. And we need to put them on a monitor because they need immediate defibrillation if they were in VFib or VTAC. But if it's just asystole or PEA, PEA being anything that is electrical on the monitor other than VTAC or VFib that is without a pulse. All right. CPR, epinephrine, CPR, epinephrine. If it is a VFib or a VTAC, I know y'all can't hardly see this, but y'all seen these algorithms. But if it is a VFib or VTAC, CPR, shot when available. Epinephrine, CPR, shock, amiodarone, epinephrine, CPR. So, same thing there. CPR is going to be your main priority. Where does intubation fall into play here? Yeah. Way on down the list. However, if you've got enough help and you can spare the resources, it may not be a bad idea to go ahead and try to intubate simply for the fact of entitled CO2 monitor. You know, never mind the fact of the definitive airway for the patient and good oxygenation and all that. Mainly because we need it to help us do our job better. Entitled CO2 management would certainly be very vital there. Remember your H's and T's. If something's causing cardiac arrest and that cause can be reversed, that cardiac arrest, those arrhythmias will continue until that cause is reversed. Okay? And then I like this little graphic right here for your cardiac meds. Didn't I show y'all this last week?
Yes, sir.
So we got a little bit of time. We'll just look at it real quick. So, if you notice here, just starting up here, you got different arrhythmias. And here, atropine. Look where it is affecting the SA node. Atropine blocks the effects of acetylcholine at the SA node to hopefully slow conduction. Okay. What about your supraventricular rhythms, such as SVT, maybe AFib RVR, adenosine? Look, it's affecting your AV node right there. Okay. What about some of your ventricular arrhythmias? Well, it's not pointing to the heart, but it's pointing to the cardiac conduction right here. Now, this is the ventricular cardiac conduction right here. All right, y'all remember this? Y'all seen this? Y'all heard about this? So you got your phase 1 where sodium rushes. Oh, not that sodium potassium pump. Oh. Yeah, it's sodium potassium pump. And you got phase 2 where calcium runs in. Phase 3, you've got your plateau phase, and you got phase 3 where you're starting repolarization. Sodium's getting out, right? So what about this? All right, so let's see. You've got a class 3. A class 3 works in this phase here. Sodium also affects the release of potassium. Class 1A, procainamide, and that one that I know how to pronounce, but I'm just not going to do it. And then you've got ventricular class 1B where you got lidocaine, which only works in that area. All right. So what is it doing? It's affecting the conduction. It's affecting the movement of sodium and potassium by whatever class it is there. Okay. Stress induced. See, this is class 2. This is where your beta blockers come in. Remember sotalol. And then you've got your calcium channel blockers here as well, where you see verapamil is a calcium channel blocker. I can't believe this doesn't have cardizem on it. So nonetheless, I would go back if I were y'all and just kind of look at the different meds there and all. It's a pretty good little graphic and understanding. That's why I went over that. I'm not expecting y'all to be experts at all of this, but I certainly am expecting you guys to understand at what areas the different drugs work. So, alright. So that was my spiel on too fast, too slow, or not moving at all. Are there any questions on that? Okay.
I have a question on something else.